Okay. Thank you very much. That was great about the challenges on for nutrition and care transition. Our next speaker is Lieutenant Commander Kibbe Conti. She's with the Indian Health Service and is at the Rapid City, South Dakota Indian Hospital. And she's going to be talking about challenges and initiatives in American Indian reservations.
Thank you, Robert. Well, good evening, everybody. I just want to say thank you to the Planning Committee. It's such an honor to be here and to learn and to share with you all. So I will just get started. I think I know how to advance my slides. This little button here. Okay. Did I do that right? No? Right hand. The right hand. Okay, got it. All right. Does anybody recognize the famous Lakota in the picture there? Sitting Bull? Anybody? Okay, very good. Okay. All right. I'm going to kind of take you a little bit on a journey out west, about as far as we could get from DC demographically. We're going to take you to South Dakota, in particular to the Cheyenne River Sioux tribe. There are 9 tribes, Indian reservations, which are all part of the Great Sioux Nation in our state of South Dakota. I'm going to focus on the westernmost Lakota, and the terms I'm using you might not be familiar with, so I put this image in here. The Great Sioux Nation is very large. There's Sioux tribes in Canada, Montana, the Dakotas, but there's a sub-tribe called the Lakota, and I'm actually a member of the Oglala Sioux tribe, and we're one of the Lakota. So all the western South Dakota tribes belong to the Lakota division. So I'll be speaking to them. Okay, geography often defines a foodway, and so when we look at this map of North America, the nations that I deal with most commonly are in this bison nation, the region down the middle, the Great Plains, the grassland. And so even though Lakota are different than Crow, which are different than Cheyenne, we do have a similar foodway. So that's something that we share in common. Okay, I've done a lot of work throughout the Lakota nations. Cheyenne River Sioux tribe is a tribe I've worked quite closely with, and I chose to use them as I guess, my example. We're looking at their foodway and nutrition. Some of the demographics that are kind of stark are the population density. The reservation is quite large, 3 million acres. It's about the size of Connecticut. Our population density is 1 person per square mile in Ziebach County. It's 2 people per square mile in Dewey County, and these are the 2 counties that make up the reservation. It's a very, very isolated rural area. Okay, so other demographics. Our poverty rate is quite high. This is according to the census data. Depending on the county, 30 to 40% poverty rate. Median household income about $32,000. Typical household size is 3.5 persons per house. The age of 65 and above is anywhere from 6 to 10%, but actually our definition of elder would be somebody in their 50s. The percentage of Native heritage is predominant in these 2 counties, 70%. Okay, one of our greatest assets in Indian country is our elders. Our elders carry so much tradition, so much language. They are our keepers of the wisdom, and they are truly, truly valued. Sadly, our number of elders is not what it used to be. Less than 5% of our population on some reservations are above that age, 65. So we don't have as many elders as we had in generations past. Okay, some of the health challenges that we see related to our elderly is, of course, the low life expectancy. And among all minorities, Native Americans have among the lowest life expectancy. And I've seen it published where it's 54 years for a Native American male. So it's very, very low. That's because of we recently, when I say recently, recent generations have very high rates of illness at younger ages. And when I say that, when I think back in my family tree to my grandparents, you know, a couple generations ago, people lived very healthy into their 70s and 80s. And that was because they didn't suffer from the epidemic of diabetes, which emerged later. So Of course, food insecurity is a very big problem, partly because of the rural nature and the kind of the food desert situation and poverty. Lack of a long-term care services is a real dire need that the tribes and the tribal representatives have been addressing. We are making some progress. I know for Pine Ridge, the reservation my family's from, we are constructing right now a long-term care facility right across the border in Nebraska at White Clay. Lack of transportation. As you can imagine, our communities are very spread out. And so a round trip to the grocery store could actually be easily 60 miles round trip. So lack of transportation's real concern. And then our built environment, or the lack of a built environment. We don't have sidewalks. We have a senior center that couldn't operate anymore because they were actually cooking out of somebody's home. And they didn't have a community center. And so that community no longer has meals because they simply do not have a place to cook. Okay, health disparities. You know, I didn't pull up all the data, which maybe I should have, from IHS.gov, but we know our diabetes epidemic emerged, depending on which nation you're talking about, at different rates. The Pima were the first to have an emerging epidemic in the 60s, but it was later in the late 70s that where I'm at, with the Lakota, that we clearly had an epidemic that was declared in the early 80s up in South Dakota. So it's still going, but we have ways to address and reduce the epidemic. We've had lots of prevention efforts, which have done amazing things to help prevent and delay the onset of diabetes. We have higher rates of obesity among our youth, our children, and among our adult population. Higher cancer rates, particularly, I know, and among the Alaska Natives, cancer is the #1 cause of death. They have very high rates. Cardiovascular disease, which could also be related, the higher rate because of all of the diabetes. Cardiovascular is a complication, can be a complication. Chronic kidney disease in my region, a lot of our diabetics suffer from kidney failure. I know in other reservations, like the Navajo, they suffer more from blindness and less so of the kidney. So diabetes affects them a little bit differently. And then, of course, alcoholism is very widespread among our population. Okay, so food insecurity, it's very high. It's 1 in 4 Native households. So our food insecure. I see this a lot when I work in a clinic setting. I work in an urban area, so I don't have as many resources as they do on the reservation. We have food pantries, though, in an urban area, so that's a referral card to the food pantry. We also have supplements. Indian Health Services provides comprehensive health care, and we do distribute, if somebody's undernourished and elder, the doctor will prescribe either Ensure or Glucerna, and we will provide supplements to help. Diets of poverty, you might have heard that expression, but it's the high starch, refined carbohydrate, high fat, a diet that really lacks any substance. We do see that. Pretty high rate of our seniors are on SSI, supplemental income assistance, and a large number of households receive SNAP. But again, you might have heard from the previous presenter, it's either SNAP or commodities. I think my next slide is the commodity food program. When I first came to Pine Ridge, this was 20 years ago, the commodity program was the dominant program. More households participated on the commodities, the FDPIR, than on food stamps. That has flip-flopped. I know when I checked back in with our commodity program, around probably 2001, they were complaining that the food stamp program had gained numbers, and they complained that it was because you have to cook commodities, and some of the items they were getting in food stamps did not really require some of the people to cook. But it's a wonderful program, though. I saw a major transformation in this program from when I first arrived in Pine Ridge. It was just all shelf-stable food products. They revamped our warehouses to have walk-in refrigeration units and freezers, and now, you know, I witnessed how we have a lot of fresh produce and frozen meat. And so this program also has a very large food package. A lot of the families that do choose commodities do so because they feel they get more from that program as far as the food amount. So we also have, even for the urban Indian population, we have the commodity supplemental food program, which is very well participated in. I think these programs are utilized, and I can't imagine if we didn't have these important programs. Our Title VI Meals program, and to a lesser extent Title III, are so vital to our communities. I am showing three, I don't know if you can see my yellow circles. I circled the 3 communities on Cheyenne River Sioux Tribe that are doing Title VI. And the director of that program claims that she served 1,300 meals in September. And this is a small Native reservation with only less than 8,000 people on the reservation. So 1,300 meals, that's a lot. It really goes far for access to healthy foods, and it's perceived very well in the community. I know they serve the seniors, they serve the disabled. Sometimes I think people can purchase a meal after they're done serving, and they will sell a meal for $6 or something like that. The tribe has also increased its support. The tribe offered an increase of about 40% just to supplement this program, to give them a little bit additional funding. Okay, and other health partners for our elders. We have senior living centers, at least for Pine Ridge. We have a kind of like an assisted living center right on the res. I know our Title VI provides the noon meal for that program. Our community health representatives are kind of like the previous presenter said, cultural liaison or something like that. That's what we have for Indian Health Services. Between the doctor and the patient, there are these tribal members that are paraprofessionals who are hired by the tribe. We call CHRs. And they're kind of our go-between. When the patient sometimes needs transportation or needs to the dialysis center or needs assistance getting their meds or getting in for an appointment, the community health representatives are amazing, and we rely on them every day. Our public health nurses and public health nutritionists do so much. I know I talked to our public health nurses about congregate dining in Rapid City because I'm in an urban area. And it was interesting because she indicated that, no, our elders aren't really doing congregate dining in Rapid City. And it's probably because, as Native, they're being a minority, there's only 15% of our population is Native American, and they prefer to get their home delivered meal, probably because on the res, it's all Native. And so if there are 1 or 2 Native people in a center that's non-Native, they might not feel so comfortable. So we don't see as much of the congregate dining in Rapid City, but we do see the delivered meals. Indian Health Services, recognizing the lack of long-term care, initiated the Elder Care Initiative. This is probably back in 2008, and it's helped to provide some funding for a few, I think like a dozen or so, tribes to try to launch their long-term care initiatives and to get those established. Another partner that's so valuable is the special diabetes prevention programs, which have been funded for years. One of those SDPI is the one that actually works with our caseload of diabetics, and where I work, we have 1,000 diabetics on our caseload. But they have a fitness center, and they really get a lot of our seniors into the fitness center, and they're well-trained staffed. And I think that's so important to get our seniors moving, and they also do a lot of community walks and everything. We have another prevention program that screens for pre-diabetes, and that's a wonderful program as well, as we do have a lot of pre-diabetics. Okay. What's really exciting, I think, is in my career, I've seen the emergence of food sovereignty. You're familiar with the word sovereignty, but food sovereignty is a term that is used a lot in Indian country. It is about having control over our local food system, the right for people to produce, sell, give away, I forget the entire definition, but basically engaging in the food or using our land for food production. And so this movement has really gained a lot of strength in the last 10 or 15 years. It's kind of been led by First Nations Development Institute. They've helped to advocate and educate Native people. one of the things that I've seen in our area is the buffalo herds. We've really seen a return to many tribes, well over 50 tribes, herds of buffalo. The Cheyenne River Sioux tribe had one of the largest herds of buffalo. You can imagine 3 million acres supports a lot of buffalo. And so that food has gone back into the diets of the people and is, as the people believe, helping to restore health. So reclaiming, restoring our former food systems that were taken away when our lands were taken and the buffalo were slaughtered, we're trying to restore that so we might be healthy as a nation. And also for the economy and economic value. Okay, kind of coinciding with food sovereignty, when I was working in Pine Ridge, I was kind of frustrated at the time with the old food pyramid, the old triangular food pyramid, because it really wasn't that evidence-based among Lakota. And if you're specifically working with Lakota people, you want to know what's going to be optimal for prevention of diabetes. And the best thing I found was interview elders and talk to the elders about what was their original food way of the Lakota. How can we reflect that today? What we came up with is right here. The medicine wheel is the symbol that you might have seen, perhaps, if you're familiar with Northern Plains tribes. It's a sacred symbol. We could explain many, many things using this symbol. But we're just explaining food, the way we're using it right here. If we look at the west, we associate the west direction with the thunder beings. The water, the rain comes out of the western direction and provides what we drink. We drink water and tea. Tea is simply a water with the herb. If we move on to the north, with the north direction, one of the symbols is the buffalo. We had lots of buffalo on our vast grassland and other four-legged animals that we would harvest, providing quality protein and fatty acids. And then on to the east, springtime is one of the symbols of the east, and springtime is when all the plants begin to emerge from the earth. And the beginning of the gathering season we associate with the east, and so their gathered plants are over there. And then the south direction, south is associated with summertime, a time to cultivate varieties of corn, varieties of beans, varieties of squash and potato. And so that reflects our traditional agriculture. And so those four things that we ate supported our health, okay? Later on, there was disruptions to our food system, and of course, our health suffered. But given the current time, that now we've seen the epidemic emerge, we understand how to prevent diabetes. The message here is that we can still honor the four things that we did so well. We can still choose a healthy drink. We can choose good sources of protein, a fruit or vegetable, and then a starchy, whole grain, either starchy vegetable or a grain that we've adopted. And so I guess it's a model that just reflects a historical foodway. And we've seen this all across Indian country. Pretty much all regions have visuals like this. It's ironically very similar to the My Plate. We published we published the medicine wheel back in 2002. We shared it at a research conference. But the My Plate we very much like. I know one of the people, or several of you guys probably were involved in this. It's a very good tool, and we have the My Native Plate, which we use all the time. So, okay, and I guess looking at how do we, promote our traditional foods, there is a lot of harvesting of our plants. We still harvest our choke cherries. We still dig the prairie turnip. We say timsila. We still, harvest the teas, the chiaka, which is our mint tea. So there's a lot of plants that are still available that are gathered. And this is where the elders partner with the youth, which is beautiful to see that partnership come together because they just work so well together. The elders have that knowledge. They teach us how to plant, how to harvest, and the youth are like sponges. So it's really good, good fit. Okay. Soup is what we associate as a traditional food among the Northern Plains. We are soup eaters. We have all different types of traditional soups. So I've included a picture there. We have dried corn soup. We have taniga, which is tripe soup. There's many soups. So that's still something we promote. We want to encourage our people to make their homemade soups. And here you see that we're coming up with a nutritional alternate for, let's say, venison is not available, but it is. I mean, there's a lot of elders that get a tag for free to harvest a venison from the tribe, but a round steak would be something that would be nutritionally similar. So, okay, so I guess I have a couple more slides here. We need to expand our wellness initiatives in the communities. We need to provide more nutrition screening of our elders and more assessments. Perhaps in the meals centers, we could do more screening and identify those at greatest risk and direct them to the resources. Nutrition education and counseling needs to be more available from quality educated or qualified people that can do that. We can do health assessments also at some of the assisted living centers. Exercise programs, we learned today how valuable it is for seniors to maintain their muscle mass. So that's another area that we could strengthen. Partnering with the food sovereignty movement, like I just mentioned, the gardening and the harvesting of traditional plants is something the elders are very skilled at and can teach the next generation. And we need to address and close those research gaps. There's very little research among Native Americans and elders. A tool that many of you use, the mini nutrition assessment, we use this at IHS when we're screening our elders. And then I'm going to close with a picture of my father, who's an elder, who's 79 and a half. He'll be turning 80 in the spring, with his sister. The two have aged beautifully. My dad's a pickleball player, and so he's very physically fit. But I guess my concluding thoughts are that there is increased attention to addressing access to healthy foods, and that this is leading to expansion of local food harvesting and production in some communities. But we also need to acknowledge that a return to valuing the benefits of traditional foods as a means to restore health is now widely accepted by Native people. They see that that is the way to regaining a strong tribe. And food is a medicine, food is medicine, is a belief in our communities that has engaged the people into the food sovereignty movement. So, thank you.